Hi, my name is Ioana Bica, and I will present our work on estimating the effects of continuous valid interventions using generative adversarial networks. This work has been done together with James Jordan and Professor Michaela van der Schaar, and it was accepted for publication in NeurIPS 2020. Now, clinical decision-making needs to be supported by evidence that treatments are beneficial to individual patients. The current gold standard for causal inference and making treatment decisions is based on average treatment effects, estimated from data from randomized clinical trials. However, randomized controlled trials generally have a narrow inclusion criteria compared to the real world, where historically population restrictions with respect to disease severity, comorbidities, elderly patients, and ethnic minorities are underrepresented. Because of this, RCTs do not provide a full characterization of the treatment heterogeneity in the final intended treatment population. So our objective is to perform causal inference using observational data such as electronic health records. And we want to estimate individualized treatment effects in order to understand, based on the characteristics of each patient, whether they would benefit or not from a specific intervention. Now, in many scenarios, such as healthcare, deciding how to intervene involves not only deciding between different treatments, such as chemotherapy or radiotherapy, but also deciding on the value of some continuous parameter associated with intervention, such as the dosage of the treatment. So in this work, we introduce SCIGAN, which is a causal inference method that can be used to estimate the effects of continuous valid interventions. Our aim is to learn from observational data, such as electronic health records, which contain information about patient features, the type of treatment and corresponding dosage assigned to them, and the observed outcome. For each patient, SCIGAN can then be used to estimate the individualized dose response curve for each type of treatment, which can then be used to inform clinical decision-making and select both the optimal treatment and dosage for each patient. Now, following Ruby and Neymann's potential outcomes framework, we assume that for all treatment dosage pairs, there is a potential outcome. And our aim is to estimate the individualized dose response curves, which consists of all potential outcomes, both factual and counterfactuals, given the patient characteristics. To be able to identify the potential outcomes from the observed data, we make the following two assumptions: overlap and no-hidden confounders. Overlap means that each patient has a non-zero probability of receiving each treatment and dosage pair. And no-hidden confounders means that we observe all patient covariates that are affecting the treatment assignment and the patient outcome. This is needed to be able to correctly adjust for the confounders when estimating the individualized treatment effects. Nevertheless, having no-hidden confounders is a strong assumption and cannot be tested in practice, and because of this, domain knowledge becomes vital to assess the validity of this assumption. Now compare the binary causal inference setting, which has been tackled by many works so far. In the continuous treatment setting, there are infinitely many counterfactuals, and we have to handle both the treatment and the dosage selection bias present in observational datasets. SCIGAN builds on the framework of generative adversarial networks to learn the distribution of the unobserved counterfactuals. As illustrated here, the generator estimates the individualized dose response curves for each treatment, and then we define a discriminator that acts on a finite set of points from each generated curve and identifies the factual outcome from the set of factual outcomes and the generated counterfactual ones. The intuition is that if a counterfactual generator and discriminator are trained adversarially, then the generator can fool the discriminator such that it will not be able to correctly identify the factual outcome by generating the potential outcomes according to their true distribution. Now we'll now go into the details of the different components of the model. So the counterfactual generator takes as input the patient features, the factual outcome, the received treatment and dosage, and some noise, and outputs a dose response curve for each treatment. We then define a discriminator that will act on a random set of points from each of the generated dose response curves. So the discriminator will attempt to pick out the factual treatment dosage pair from among the random set of generated ones. And to handle the complexity arising from multiple treatments, we propose a hierarchical discriminator consisting of a treatment discriminator, which needs to identify the factual treatment, and a dosage discriminator, which needs to identify the factual dosage. The SCIGAN generator and discriminator are trained using the adversarial game described here, for which we prove that the optimal generator needs to learn the counterfactuals according to their true distribution. Now, in terms of the model architectures, we use a multitask neural network for the generator, and each multitask head will generate the individualized dose response curve for each different treatment. Moreover, to ensure that the discriminators can act as functions on sets of randomly selected dosage outcome pairs, we build them as permutation invariant and permutation equivariant neural networks. In particular, the treatment discriminator will receive all of the sets, one for each treatment, of dosage outcome pairs, and output a probability for each treatment, indicating whether it's a factor one or not. That is, there is one output corresponding to each set. Thus, to build a treatment discriminator, we treat each input set of dosage outcome pairs as a vector, but require that the outputs of the discriminator to be invariant to the ordering of the elements in the set. On the other hand, each dosage discriminator receives as input a set of dosage outcomes pair corresponding to a given treatment and is tasked with outputting a probability for each element in the set. And in order to define such a function for a dosage discriminator, we consider the input and output as vectors, but then require that if we permute the elements of the input vector, the output should also be permuted in the same way. And to do this, we use permutation equivariant layers to build the dosage discriminators. Now, since in real data sets counterfactual outcomes are never observed, synthetic data generation models are needed to evaluate causal inference methods. While there are well-established benchmark synthetic models for the binary treatment setting, no such model existed for the dosage setting. So in our paper, we propose a new semi-synthetic data generation process for continuous interventions that enables us to vary both the treatment and dosage selection bias. We evaluate the benchmark models on 3 different data sets, TCGA, News, and Mimic, and we use as evaluation metrics the mean integrated squared error, the dosage policy error, and the policy error. We also perform additional ablation studies and test the robustness of the methods to increase treatment and dosage selection bias. Overall, SCIGAN achieves improved performance over the evaluated benchmark models across all of the different data sets. Thank you for listening, and if you're interested to find out more about SCIGAN, check out our full paper here.